Pam Freilich is the CEO of the Canadian Healthcare Association, a very important partner in this whole initiative. And so over to you, Pam.
Thanks very much. Merci, Terry. I will be very, very brief. You have the program introductions, and I'm sure you'll be able to read those. 4 quick points to make, however. First of all, disclosure, and often in scientific presentations there are disclosures right up front, and because he probably won't mention it himself, I feel it's incumbent upon myself to mention that the moderator of our previous session, is Kaveh still in the room? Yes, Kaveh Shojania is the nephew of Dr. Lee, so there's the first disclosure. Second point I need to raise, yes, Dr. Lee is from Harvard. No, he does not know Jeremy Lin, so no basketball questions. However, his daughter does, so you might want to probe a little bit. To get a little bit more serious, and again, I know that you have the biographical information, but I do want to at least point out that Dr. Lee is, in fact, still a practicing physician, obviously practices. He's an internist and a cardiologist. He is the network president for Partners Healthcare System, which is an integrated delivery system founded by Brigham and Women's Hospital and Massachusetts General Hospital, and he's the chief executive officer for Partners Community Healthcare. And the reason I want to highlight that first piece is that the theme that is so important for me and my organization, Canadian Healthcare Association, and the day-to-day is about integration. I'm not sure we've hit the mark or not, especially based on the conversation towards the end of this last panel. So with integration being so important to us, and having clearly an expert who can speak to us about that and his experiences and other things, I'm sure, I'd like to ask you to join me in welcoming Dr. Thomas Lee.
Thank you, Pam. And yes, if Kaveh had left after a session, I was going to tell his mother, and he was going to get in big trouble. But no, I hope that this last session of the day will be useful to you, because we're struggling with the same issues down in Massachusetts with my colleagues, the Brigham and the General, and the community we have, the community network that we have as well. And the big challenge, as I was saying to Kaveh and others at lunch, is I was realizing and the reason you're here is, we're all struggling to create social capital. Everyone knows what financial capital is, but financial capital enables your organization to do things that otherwise couldn't do. But for the challenges that we face, and really our patients face, living with chronic diseases, living with complex diseases, how we work together to help them. That's what social capital is about, like figuring out the nature of relationships, making them work so we can do things that we otherwise couldn't do. The truth is, we're all making a lot of progress. I think that although there are times where it feels like we're trying to boil the ocean, we have discussions back in Boston that are ideological about who will be running things. The truth is, those discussions, they don't really help that much. And what does help is actually focusing on patients, meeting their needs, and the path forward that I'm going to describe. It is the path forward that we're using in Boston at Partners, where we are an accountable care organization. We are taking risk on as doctors, hospitals, non-acute care, all of us together. We're taking risk on hundreds of thousands of lives now, facing the potential losses of like $100 million or some ungodly number every year. So we are really worrying about it. But the taking the risk, that doesn't answer the question either. It's how better, more efficient care happens like at the front lines. It's how we work together that really matters. The taking risks together, that kind of thing, is just sort of a means to an end to what, and I actually don't think you need the big ACO structure to begin making meaningful steps. So I'll tell you what we're doing. And one thing I do want to say before I start getting into specifics, actually, one thing I should say is everything I say about partners will sound better than it actually is. And I'm not saying that to be cute or something like that, but it's just when you're trying to hit the high points, you're glossing over all the dysfunction, the headaches, and so on. And I'll try to be honest with you. But so with that, full disclosure thing, I will say there is the sense among many of my colleagues that something magnificent is going on in our times, that we're living through something really historic. And I compare it to what happened in medicine itself in the second half of the 20th century, where fatalism left medicine in the second half of the 20th century, and I believe fatalism is leaving healthcare delivery in our times. So, the second half of the 20th century was our times for many of us, and many of us can remember the change that's occurred. I use myocardial infarction as the example, where mortality in myocardial infarction, in 1960 was 30 to 40% versus like 5 to 8% today. 1960 is not that long ago, but 1960 is when CPR was described for the first time. In 1960 when defibrillators were described for the first time. And 1962 was the first coronary care unit. And when the first coronary care unit came along in 62, mortality immediately was cut in half. And then there's been many, many incremental changes ever since. And when I was listening to the team discussions this morning, one of the things that it reminded me of is the coronary care unit was one of the first real team functions in healthcare. We concentrated the patients in one setting. We concentrated teams with expertise in one setting. And the CCU, if you go back and read the history of them, it was striking to the people living through those times that for the first time, nurses who were virtually all women were empowered to act without waiting for the orders of doctors who were virtually all men. They would just defibrillate people who were in ventricular fibrillation. That's how mortality fell in half. It was effective teams and concentrating the patients with those teams. Now, for those of us who can remember before 1962, I was only like 8, 9 years old, but that was that's when Dr. No came out. The first James Bond movie, not really that long ago. But we were very fatalistic about myocardial infarction. The three terms people used were unpredictable, unpreventable, untreatable. You just put them in a bed and you hope for the best. You defibrillated them if they coded. And we're anything but that today. The term risk factor wasn't introduced until 1961 when the famous paper from the Framingham study. Now, I go through that to say, we are so non-fatalistic today with so many conditions in medicine, and it is great. It's magnificent that we're living in these times. There are things that we were fatalistic about, like in 2005, I actually said at a public meeting in Boston, that I thought this stuff about bloodstream infections going to zero was ridiculous, because as long as there's bacteria on the outside and lines going through the skin, there was going to be some finite rate of infections, and I thought we were pretty much doing everything that could be done, and the rates were probably what they were going to be. And I was clearly wrong. This graph on the right these are the rates of bloodstream infections per 1,000 ICU days for patients in the intensive care units of the hospitals and partners healthcare system. And it has been many, many little best practices that are being shared that's been driving the rates down. My very favorite is an emergency department nurse at Mass General who came up with the idea that when they're putting in lines during codes and the patient makes it and gets to a unit, they should put some colored tape around those lines so that the people in the units know this line was put in a less than ideal circumstance and it should be changed. Now, that's something that, you could have perfect performance of whatever your bundle is in the ICU, but it would never get at this idea of contribution from someone in another part of the system. Now that has become standard practice across our system. We were unsuccessful in getting everyone to adopt the same color tape, because blue means something at Mass General, red means something different at Brigham, and so on. But that is the kind of thing that is taking fatalism out of many things that we were philosophical about. Falls, readmissions, we felt like it's part of life. But now we know that they may not be within our control, but if we actually work together in some new ways, they might be under our influence. Now, as wonderful as that sounds, we get stuck all the time. And I have this little list of, it's my running list of reasons why we get stuck. Before you look at the list, let me just give you an example of what I mean by stuck, just so you know I'm living in the same world as you. One of the things I'm obsessed with right now is the consultation process and how it works. And we gathered a little data. You know, like there are 150 new neurology consultations per week at Brigham and Women's Hospital, about the same as Mass General Hospital. It takes like 2 or 3 months to get in for one of those new visits. They're booked for 1 hour. 80 out of 150 patients walk in with a disc with images that no one has looked at before. When that happens, the neurologist heaves a sigh. 80 out of 150, so most new consults. When that happens, chaos ensues. The neurologist sighs, thinks briefly, why don't I just order another MRI? But then usually will get up, walk down the hall, up a flight of stairs to neuroradiology, interrupt the neuroradiologist, stand there while the neuroradiologist finishes reading the image. I mean, I know all this because we're mapping out the process. Wait, try to load it, and eventually, usually, we'll get a reading of the image and then go back. Much of the rest of the visit, the neurologist is thumbing through papers that he or she has never looked at before, and then trying to schedule things. Only about 10 to 12 minutes is actually the neurologist really interacting with the patient. Now, I don't think, I can tell you this because I doubt that it's hugely different for you guys. We all know what would be better. You know, what would be better is if we started taking care of you, not when you finally get in our door, but from the moment the referral's made. That we start collecting the information, getting the images, and saying, oh my God, you got to get in right away and get you into the front of the line. Even if I only had to wait 3 days for a neurology consult, I would be going crazy in those 3 days. But if I knew someone was collecting my information and processing it, I would feel differently about it. I would feel calmer. And we might have 30 minutes or 40 minutes for those new neurology consults instead of 60, and we might be able to have more throughput and be able to take in more patients. And I mean, ultimately, you know, we want to be taking care of sick people who really need our operating rooms and our scanners and our hospital beds and so on. We don't want to be, you know, seeing patients who don't really need us. You can't build a good business based upon that. So, but the reason we can't make that investment up front is like the, you know, 4th bullet point down there, because we haven't costed out the cost of the defect. And so I can't, at this point, make the case for spending the money on the system up front, because I can't say something about the money that will be saved downstream. And in our system, as I'm sure is true in yours, we have 20 wonderful ideas for things to do with every single dollar that we have saved. We're considered a wealthy system. I don't have the ability to just say, let's spend money on a system where we gather data up front because it makes so much sense, let's just do it. I feel that way about many of the wonderful ideas I've heard about out here. You know, the out there in the posters, the one on the right with the consultation service with people just doing things by telephone, or the Navigator Clinic for mental health. The thing I wanted to find out, but I didn't have time to actually ask people, is, you know, is there a funding mechanism which will allow that kind of thing to spread? My guess is probably not, because you have the same kind of challenges that we do. So why we get stuck? You know, we don't have clarity on what we're trying to accomplish. We don't have a performance framework to show that. If you can't show that something is different because of what you're doing, it's very, very tough to ask for greater investment in it. And the truth is, you're vulnerable to have whatever investment's being made in you taken away. We don't have data on the outcomes that matter. We don't have data on the cost, as I indicated. We're not organizing the functional teams, and we're not being paid to actually improve value. Now, we're not actually starting from ground zero on all these things, but in attacking these reasons why we get stuck, and some of you have heard me describe this before. So, Kava had me come to Toronto to talk about this a year ago in one of his patient safety symposia. The way we are packaging it for our colleagues is, and I'm a little embarrassed doing it this way, but I'll apologize and explain why I do it in a second. But the way we package it is Porter strategy, Gawande tactics, Boehmer operations. And we do that because the truth is, I am a professor at the medical school and so on, but we have work to do. I'm mainly paid to actually deliver care, and we can't be abstract. We have to make progress, and so we need to actually engage our folks. And I'm going to be explaining how we do that in a second. But we use the three names not because Michael Porter and Atul Gawande and Richard Boehmer from Harvard Business School are the most brilliant guys in the world and they've cornered the market on great ideas, not because Boston and Harvard have cornered the market on ideas, but we do it because everyone in my organization is like me. We are better at gossip than we are at ideas. And when we hear three names, people kind of perk up. And then, and you see them go, well, he's not so great. I don't know what the big fuss is. All this and that. But they wake up and they remember what it is we're trying to do. And what we're trying to do is relatively simple. I added a couple slides based on the morning's discussion, because I think some of the themes that run through these colleagues' work is so similar to what you guys have been talking about all day. So again, Michael Porter, Harvard Business School professor, and the strategy part is value is defined by patient outcomes and costs as the organizing strategic framework for healthcare delivery organizations. Atul Gawande, surgeon at the Brigham, who is probably best known as the driver of the World Health Organization surgical checklist and the author of the Checklist Manifesto. And Richard Boehmer, who may not be the rock star that the other two are, but whose work I think is very, very important and valuable. Really, he teaches and writes about teams that permanently own the work of improvement. And I'll come back to these guys as we go along. So let me say something about Michael Porter and his work. And I got to tell you that until 3-4 years ago, I paid very little attention to him or no attention at all. But now, I've actually developed a very good relationship and close relationship with him, and I really do feel that his ideas are ideas whose time has come. They're certainly very valuable for the folks in my organization. And the reason why we've gone from rolling our eyes when his name comes up to actually more and more of our folks are taking courses that Michael's putting on. Michael has putting on courses within partners for residents, fellows, young faculty. We have to face this fundamental question, and it's come up and several times during the previous discussions. What are we actually trying to do? What is our reason for getting together and sitting around tables together? When I'm sitting across from a patient, I know what I'm supposed to do. I'm supposed to do what I can to help them. But when we're sitting around tables as an organization, what's the goal? What's the purpose here? And we need an overarching goal that everyone agrees on, because without an overarching goal, what we do is we play games. And I don't mean that in a pejorative way, because I play those games myself a lot. But gamesmanship, it's gamesmanship where you're trying to protect your way of life. You're trying to make sure that you can continue to do what it is that you do and have a decent income as you do it. Now that sounds really bad, but it's completely understandable. And the thing that the light bulb for me was my middle daughter, who's a social studies major in college, telling me about something she learned about in sociology class, moral disengagement. When people focus on something good they're doing and they allow themselves to block out everything else, all the other consequences. And it's usually used, in writing about terrorism, soldiers, corporations that focus on one thing and they ignore the impact of everything else they're doing. But we kind of do that in healthcare. We're doing something really wonderful for people, and we don't want to hear about the impact on the economy or the other or the people who can't get care. So So in that gamesmanship world, which is the world most of us grew up in, the people who get their way, who get the bigger investment, who get the nicest offices and so on, they tend to be the people who are doing the things which make money. They tend to be the people who scream the loudest and everyone is scared of ticking them off. The people who are smoothest and slickest and best at the political stuff. And that's all well and good, I mean, but it's not going to allow us to do the remodeling of healthcare that's needed for our times. So we went through a whole lot of discussion about what are we trying to do in our organization. As again, this is doctors, hospitals, and we're in a state, Massachusetts, which is committed to covering everyone, and we knew the pressure was going to be tremendous on us to try to redesign care. So what we ultimately decided was, after a fair amount of agonizing, is that we do have an overarching goal, and first it's improvement, to actually try to be better next year than we are now. That's consistent with our culture in theory. In reality, a lot of our folks did not really think, want to be pushed to be improving, but part of saying improvement is the shared goal. That means that if we're not improving, we're failing. And that people hate that word in our culture. But then what are we trying to improve? Well, what we're trying to improve is value. Outcomes that matter to patients over costs, over meaningful episodes of care. That means not focusing on process measures, the traditional concepts of quality. My clinician colleagues, myself among them, we've always been pretty good students. We wanted to be evaluated on the basis of things under our control, things that we could just do and we would get 100% on our test. This is recognizing that our reliability on the clinical side, that's not the issue. People aren't even that interested in that. What they're interested in are the outcomes for patients and what's it going to cost to deliver them. So we're not as interesting as we think we are. So let's put the attention on outcomes. And when you put the attention on outcomes, it puts folks in a different frame of mind. It's not about playing defense of your reputation. It's about problem solving. Learning from other people, improving through collaboration. It's actually harder but more exciting, and I believe thrilling. It'll be thrilling for me and thrilling for many of you as well. So these are slides that we use to explain this to our internal audiences, clinical and non-clinical. This is the Michael Porter stuff, really simplified. It's value, outcomes over cost. It's not process measures. The box in the on the lower right is the message we wanted to reinforce to them is that we are focusing on improving value for patients because it's the only thing that we can find that everyone agrees would be a good thing to improve. We can't find anything else. And when I say everyone, I mean not just all clinicians and everyone else in healthcare, but the insurance companies, the government, patients. Everyone wants better outcomes delivered more efficiently. No one is ready to step forward and say, my personal interests are more important than improving value. They may be thinking it, but they at least know that it would be really bad to say that kind of thing, and so they don't. Going one level deeper, we're going to be moving from abstract to non-abstract over the next several slides. Again, this is many of you want to go deeper in this. Like Michael Porter and I wrote 2 little articles in this a year and a half ago in the New England Journal, in December 23rd of 2010, sort of laying the stuff out. But Michael's framework is that there is no one outcome that tells the story for any patient condition. There are multiple outcomes, and you have to look at the performance in terms of patient conditions. It's not just conditions like diseases like heart failure and so on. We're really trying to do is segment patients into groups with similar needs so that we can organize ourselves around meeting those needs. The simplest, patients with certain conditions tend to have similar needs, but there are other segments of patients, like the patients with multiple diseases, the complex patients that was the focus of a lot of discussion this morning. They've got similar needs for care coordination and so on. Patients who are perfectly healthy have similar needs. So it's really trying to organize around patient segments, which are often defined by conditions. But for any patient segment or condition, there's 3 tiers of outcomes of interest. They're the tier 1 outcomes. They're the ones that matter most: survival, functional status. But it's tough to pull away from the crowd based upon them because it's tough to improve on them if you're doing a good job, because the biggest determinant of how well people are going to do is how sick they are. You can't be worse than other folks. If you're worse than expected on tier 1 outcomes, then that is an emergency. That is all hands on deck, and you got to do everything you can until you've addressed that issue. But let's just assume that you're, a good organization, you're doing well, and you're in the game on tier 1 outcomes. You're always going to try to do better, but let's be realistic. You're probably not going to, you may not be able to really improve when so much of a driver of that is how sick the patients are coming to you. Then there are tier 2 outcomes that you should be trying to improve. If you're trying to improve value as your reason for being, then that means improving 1 or more outcomes without raising your cost, or lowering your costs without hurting your outcomes, or ideally doing both. I mean, that's not abstract, what I just said. I mean, that's something that's easily measurable, and you can tie money and performance reviews and that kind of thing to that. So tier 2 outcomes are outcomes related to the process of care. How long does it take things to happen? How long between, it matters to the neurology consult patients how long it is before they're seen, when they're wondering, do they have multiple sclerosis or something, or a brain tumor or something like that. The disutility of care. One of the things my colleagues and I are focusing on is unnecessary anxiety. There is going to be anxiety in healthcare, but there's anxiety and there's unnecessary anxiety, and we know that there's some anxiety that's within our control to do something about. There are lab results that sit on people's desks through the weekend or on the computer that, if someone just let the patient know, if the computer system was available, the patient could look it up themselves, that would reduce the patient's anxiety. That's an outcome. Now, tier 3 outcomes are outcomes related to sustainability of health, so that a hip replacement that lasts 2 years is not the same as one that lasts 15. Now, one of the insights that came from working with us and other providers to Michael is that this framework is not really about competition. I mean, his famous 2006 book ends with the word competition in the title. He'll now say, it's not about competition. You can't really compare value from one institution to another. You can't take multiple outcomes, add with different units, and add them up and divide them by a dollar number and say, oh, we're 1.4, you're 1.2. We knew we were better. You just can't do it. It's not really for the external world. It's not for customers and consumers. It's for us. It's for us trying to improve who we are. And the way we improve is we try to improve 1 or more outcomes and or lower the cost. And how do you do that? Well, you look around and and one of the reasons I'm here is because I'm hoping people here will be measuring things the way we're measuring them, and that we'll learn some things from you and vice versa. You learn by looking around, and usually what you see is that people are collaborating and working together in ways that you hadn't thought of. I'm going to come to one of those ways that Cobb and I were talking about during the break in a little bit. So, this is one of the slides I inserted after listening to things this morning, because one of the things you can get paralyzed and feel overwhelmed by the challenges we have in front of us, but I think one of the things that we really believe is you can just get started, and the way to get started is really the top 2 strategies are the most important. Measure the outcomes and costs from meaningful episodes of care. and then develop integrated provider units, integrated practice units, teams of providers that are organized around meeting the needs of those patients. And then, it'll be great if you can, then you can start like working to change the reimbursement system so you get rewarded, and integrating those IPUs with the rest of the system, and the other strategies. But the big ones, and this is what I'm telling the young people who come to me like looking for projects and that kind of thing, I tell them, like, let's find a condition that you're really interested in, and let's create the value report card for that condition. And as soon as people start looking at their numbers, people are competitive and they want to do the right thing. They want to get better. And they will start thinking, all right, then what do we do? And it'll drive good things, drive good discussions after a certain amount of kvetching about the data, of course. But then if you can organize an IPU, the equivalent of the CCU, a team for patients with chronic kidney disease, a team for people with heart failure, where you're calling people to make sure they're okay, then you can start moving the needle on those things. So the way we're doing this at Partners, we've been going down this road now for a year now, really just a year and a half, 2 years. So it's not like anyone's miles ahead of anyone. But we organize teams around certain diagnoses and sets of needs, like high-risk complex patients, as you guys have been discussing so much this morning. The teams have, their first job is to define value, define what it is that we're trying to improve. And we've got version 1.0, and now, actually, in my briefcase, I was showing Kava this morning, version 1.1, the second edition, where all of these are things we can actually measure now. But then we also ask them to define the outcomes and resource use things we should measure, that we should, but we can't. And I'll give you a taste of that in a little bit. And then, having defined what it is that we're trying to improve, having created the playing field, the scorecard, so we can know whether we're improving, then we say, okay, well, how the heck are we going to improve? Well, that's where the Gawande part comes in. What are the pause points and the checklist at those pause points where, if we were really reliable, we might be able to, or we should expect to be able to, improve outcomes. I'm not going to go through all these, and I'm just going to give you a taste of things, because I want us to have some time for discussion. So, the teams talked about, we defined the episodes over which they'd be trying to improve value. And I just put this up there to emphasize, it's not just the hospitalization. This isn't about the hospital. This is about patients. And all this stuff about, is the hospital going to take the lead, or the doctor's going to take the lead? The way you deal with that issue is you put patients in the middle of things. You organize around patients. That's the only way those discussions fade into the background. Otherwise, it's going to be jockeying forever. And so you talk about patient episodes that transcend hospitalizations. Ideally, you can avoid hospitalizations. One of the things I enjoyed most was, like, we proposed that for the stroke team that their episode be up to the first 45 days after a TIA stroke, and their reaction was, that's not long enough to show the benefit of what we could do. We want 90 days, and so that's what they've been working with. So I know you can't see this, but I just want to give you a feeling for what I mean by a value report card. So it's outcomes over resource use. It's on the same page. Sometimes, they're on facing pages, but they've got to actually be, you've got to be able to look at them at the same time. And these are hospitals in our system, and Brigham, Mass General, North Shore Medical Center. And the interesting thing, what we are finding, and there are no process measures. I don't want to see process measures on these pages. It's not about reliability. It's how are the patients doing, what's it costing. And the thing that's really interesting is that you get different conversations when you put outcomes and costs on the same page in front of people. You don't get, first, it shows life as it really is, which is so complicated that it's tough to say anything that means anything, like someone good, someone bad. it shows that there's almost always something to learn from someone else. And people look at these pages, and ordinarily, if you just show outcomes, the ones who are doing better will go, I knew I was better. And the ones who are doing worse will just go, you haven't adjusted for this and this and this. But when you put a whole bunch of outcomes on the same page with resource use data, people look at it and they appreciate life in its complexity, and they say, well, who's doing better than me in this? And who's doing better than that? Well, who might I learn from that? And, well, some people just go, oh my God, I can't, they have like a panic attack, but then they get down to the discussion of how do I learn to get better? So these report cards, what I'm doing with the young people who come to me looking for a project, say, okay, you're interested in chronic kidney disease, let's work on our performance report card and let's begin to figure out what data we have and build the interfaces. Now, like when I talk about the value report version, value dashboards 2.0, and again, this is kind of what I mean by putting patients in the center of things really does change things. When we talk to our stroke patients and our heart failure patients and others, they don't think readmissions is such a good measure. What they want is to be home. They want to maximize their days at home. They're actually willing to take a greater chance of being readmitted if we will get them home a little sooner and if it leads to a greater number of days spent at home. It makes perfect sense. That would be me if I were in the hospital. So we have no idea how we're going to measure days spent at home out of the first 90 after stroke, but we actually have some ideas. But we're actually testing some now with a company for collecting these kind of data. Sphincter control, locomotion. Our doctors aren't asking people these things, and we can't ask anyone to ask these things. We have to create some new ways of collecting these kinds of data so we can know who's not doing well. Actually, people use the phrase evidence-based medicine a lot at lunch. We're actually saying, well, we need measurement-based medicine. We need to collect data that we have no idea how it's going to make us better. We doubt it will make us worse, but we need to actually be collecting outcomes that matter to patients and putting that information in front of our clinicians when it's not going well. So this is my favorite project. I don't have numbers in these cells, but this goes live in a couple of weeks. The team working on it won't give me any numbers because they're afraid I'll show it to people. But this is we won't call it a value dashboard. I thought I'd change that, but I hadn't because we are a little concerned about the Tea Party in the United States. But we've taken this value framework and we're applying it to the patients who die within our system. We actually have a whole portfolio of things for the critically ill patients in general, but we are having a report card. This report card will be for every patient who dies in Partners Healthcare System, even if they die outside of our hospitals, but they're followed by our doctors. And the version 1.0 is what the data we have now, were they in ICU, did they get made DNR, how long between when they were DNR until they died, did they get chemo in the last 2 weeks of life, that kind of thing. And people are so anxious to see this data. And people, not just us, but MD Anderson, Yale, Cedars-Sinai in California, other people are seeing this and they say, we want to do this too, and we want to see, and we want to find a way to comparing these data among us. They'd be nervous if it was all on the internet, but they want to learn. Now, how are we going to move the needle on this? This is like Atul Gawande actually is leading the Gawande part of our end-of-life work. So, so Atul has been leading a group to develop the checklist for what's a good end-of-life discussion. So it's a 7-question checklist, and what's your understanding of your prognosis? Do you have any goals that we should know about, like getting to a wedding or so on? Are there states which are unacceptable to you? Are there trade-offs that you would be willing to make? Have you discussed your feelings, your thoughts on these issues with your family? So that's there are a couple more questions, and I think there's a good chance that if we are using that checklist for patients in certain situations, like when they're diagnosed with a metastatic cancer and so on, again, I'd be surprised if it makes us worse. But I don't think I could be lobbying for investment in this kind of thing unless I had something like this to show that something's changing as a result. So this is the Gawande part. I think you guys all know about that stuff. The themes in the recommendations coming out, like I'm not going to go through all of these because of the time, but like, the one that I was talking with Kav about during the break was, scheduling and navigation functions. Like I'm on the board of Geisinger Health System, and at Geisinger, their readmission rate's quite a bit lower than our readmission rate in Boston. And I know it's not because they're smarter than us, but one of the things at Geisinger is when you leave, 85% of the patients who leave the hospital at Geisinger leave with a definite appointment of when they're going to be seen and follow up. And that appointment's usually within a week. Now, at my institutions, is 22%. And there were some samples we've done where it was 4%. And I think you probably know that when patients don't leave and they don't have a definite appointment, their chances of actually being seen, showing up and so on are much lower. So the reason Geisinger can do 85% is because their physicians have given up control of their scheduling to the system, so that a case manager, no one has to talk to anyone in Dr. Lee's office to schedule an appointment. They certainly don't speak to Dr. Lee, but they don't speak to Dr. Lee's secretary. They can just access the appointment schedule and book the appointment. Actually, at Geisinger, for the employed physicians, patients can book their own appointments online, like Expedia. And physicians have this illusion that control of their schedule means control of their life. It's hopeless. Your lives are out of control when you get an MD. Giving this up, though, is a very big deal. But I have on my whiteboard, I have a little list of, it says CTJ questions. That stands for Come to Jesus questions. And one of them is, will you give up control of your scheduling to the system in the interest of patient care? Put that way, it's hard for people to say no. But they don't. Believe me, they haven't all jumped to say yes, but the scheduling thing is a very, very fundamental thing. Having patients know exactly where they're supposed to go next, it's a basic step. I'm going to skip this stuff. I'm going to skip this Geisinger stuff so we can get to things. Boehmer operations. Okay, this is the Rich Boehmer stuff. This, he's not the rock star as the other guys. He only gets one slide. As a result. But his stuff is important. It's about teams that have the responsibility for the improvement of value forever. I mean, Richard's value set that he's trying to communicate, it is like the Toyota value set. It is the endless pursuit of perfection. There is an Asian cultural, theme that, like, if any of you watched Jeremy Lin's interview on ESPN last night after the game, where he was talking about how badly he did covering Calderon and how his teammates bailed him out. That to me is like, the Asian thing is like, we're not good enough. I'm not good enough. We're not good enough. We have to try to get better. That was either that or he's had very good public relations coaching. But so that theme of we're not good enough. We have to try to get better. That is why we exist. That's what Richard Boehmer's theme is. So you need data on outcomes and costs collected as part of routine care. You need incentives, financial and otherwise, for improvement. A leader doesn't have to be a physician by any means, and often it's better if it's not a physician, because you need someone who is going to think every single day about how can we improve performance for our team, and you need formal and informal interactions among team members. So when you look at the work of these three guys, these are 10 words that run through, that I sort of was sifting through the work that come up over and over again. Value, measurement, outcomes, efficiency, improvement, learning, collaboration, humility, discipline, teamwork. These are good words. And I've heard these words all day. Listening to your folks. And that's why I felt like I added more of this stuff, because I feel like this is not going to feel like a foreign framework, to you guys. So my last slide, this is a room full of people with wonderful intentions, as is true whenever my colleagues get together too. But turning those good intentions into higher value, just to summarize the themes I hope you'll take as the take-homes from my talk, we need clarity on the goal. You need, and I think the right goal is improvement of value for patients. It's not provider reliability. It's provider reliability is it's just a means to an end. It's not what the game is about by any means. And it's improvement. And how do you improve? You measure things, you learn things, you figure out new ways to work together. You get into that problem-solving mode. One thing, I don't have an MBA. I've never taken any business courses. I work with a lot of MBA types. And the thing I admire that they learned in school that we did not is problem solving. Taking a problem, breaking it down, attacking it, just keep on beating at it until you've done what you can. We kind of do that with diseases on the clinical side, but organizationally is that same kind of problem solving, functionality, which I find exciting. A performance framework so you can actually tell whether you're making progress. Then getting the data on outcomes and costs. That is the way, and if I were you folks, and the folks I listened to today, had lunch with, and so on, I would say we're not going to solve all these big questions that we talked about in this room today. But you know what? We can start collecting data on outcomes on some conditions that we measure. Believe me, at Partners Healthcare, we will share with you what we're collecting, and the more people that we have to benchmark with, the better. And then organize teams around meeting the needs of patients in those segments. And those teams should be real teams. They should have a leader. They should have meetings where they actually get together and formally and informally. And then they need an incentive system. Doesn't have to be money. Money helps. But money's not the only incentive by any means. So with that, we're almost back on schedule. And so let me turn it back to Terry. Thanks very much.